So this is a review of acid-base imbalance. So you're either going to have acidosis or alkalosis. So acidosis is excess hydrogen ions resulting in a decrease in serum pH. Alkalosis is deficit of hydrogen ions resulting in an increase in serum pH. And remember, serum pH has to be in that tiny little range in order for anything to work at all. So metabolic acidosis is a decrease in bicarbonate. So pH is down, bicarbonate is down, and CO2 is the same. Respiratory acidosis is due to an increase in carbonic acid. So pH is down, carbonic acid or CO2 is up. So they're opposite. Respiratory opposite, metabolic equivalent. Metabolic acidosis or metabolic alkalosis is an increase in bicarbonate. So pH is up, bicarbonate is up. Metabolic, they're the same, they're equal. Respiratory alkalosis, pH is up, carbonic acid is down, they're opposite. So respiratory opposite, metabolic equivalent. That's our ROME is our acronym for that. Respiratory opposite, metabolic equivalent. So acidosis, if it's metabolic, pH is down, bicarbonate is down. CO2 is normal. If it's respiratory, pH is down, carbonic acid is up, and bicarbonate ion is normal. Alkalosis, if it's metabolic, pH is up, bicarbonate is up, CO2 is normal. Respiratory alkalosis, pH is up, carbonic acid is down, CO2 is down, and bicarbonate is normal. So we'll go through that again too, because it bears repeating because that's how you remember it. So here are some different causes and effects and the compensation and what you're going to see on the labs for acidosis and alkalosis for respiratory and metabolic. And this is one of the lovely tables in the book. How much I love those tables in the book. So for respiratory acidosis, slow, shallow respirations can cause it. So drug overdoses usually cause respiratory acidosis, and that's what kills you because they depress your respiratory system. So you can't exhale your CO2. You're basically drowning in CO2. Or respiratory congestion could cause it as well, or chronic obstructive pulmonary disease. The effect is increased CO2 levels, so increased carbonic acid. The compensation is the kidneys excrete more hydrogen ions and reabsorb more bicarbonate. So they're trying to get rid of hydrogen to lower the hydrogen level and increase the pH. It compensated, so our laboratory is going to look like elevated CO2, and it's respiratory, so the pH is down and the CO2 is up. Elevated serum bicarbonate, and that's from the kidney response. And it might be that bicarbonate is normal too. If it's compensated, the serum pH is between 7.35 to 7.4. So it's acidotic, but it's not horrible. If it's decompensated, it's less than 7.5, meaning the compensation systems aren't hacking it anymore. And we're getting down to that bad range where you could die. It's not good. But if pH is less than 7.8 or 6.8, then that's not good. So for metabolic acidosis, it could be caused by shock, any kind of shock. We'll talk about different kinds of shock at some point. Could be caused by diabetic ketoacidosis. It could be caused by renal failure. It could be caused by diarrhea. The effect that causes the symptoms is decreased serum bicarbonate ion. The compensation is first respiratory, rapid deep respirations to try to blow off CO2 and get rid of CO2, carbonic acid. And the kidneys excrete more acid and increase bicarbonate absorption. So you can see the compensation is the same in the kidneys, whether it's respiratory or metabolic. Your laboratories, you're going to have low serum bicarbonate because the serum bicarbonate is being taken up by all that extra hydrogen. We're going to have low CO2 levels. So not high. So low pH, low bicarbonate, they're the same. If it's compensated, the serum pH is 7.35 to 7.4 and decompensated less than 7.35. So for alkalosis, it can be caused, but respiratory alkalosis can be caused by hyperventilation from anxiety or an aspirin overdose. So because you're blowing off all your CO2, and so your pH will be higher. So pH is high, CO2 is low, they're opposite, it's respiratory alkalosis. Low CO2 in the lab. The kidneys are going to excrete less hydrogen ions and reabsorb less bicarbonate. Low CO2, low serum bicarbonate. If it's compensated, the serum pH is going to be 7.4 to 7.45, the top of that range. If it's greater than 7.45, it's decompensated. So metabolic alkalosis can be caused by vomiting in the early stage because we vomit up all our hydrochloric acid. Or excessive antacid intake. The effect is increased serum bicarbonate ions. So increased pH, increased serum bicarbonate, that's metabolic. The compensation is slow, shallow respirations and kidneys excreting less of the acid and decreasing bicarbonate absorption. So in the lab, you're going to have elevated serum bicarbonate. We have high pH, elevated serum bicarbonate. They're both going up, metabolic. We're going to have elevated CO2. Compensated is from 7.4 to 7.45, just like with respiratory, and decompensated is greater than 7.45 pH. So hopefully that is kind of starting to make sense. Or, if it's not, we'll talk about it. It'll be fun. We'll talk about it. So respiratory acidosis can be caused by chronic or acute issues. Acute problems that can cause respiratory acidosis are pneumonia or airway obstruction or chest injuries, or drugs that depress the respiratory control center. Chronic problems that cause respiratory acidosis can be chronic obstructive pulmonary disease because they have trouble breathing out. Decompensated respiratory acidosis can develop if whatever impairment is causing it becomes severe or if compensation mechanisms fail. And that's always the case with decompensated, any kind of acidosis or alkalosis. So metabolic acidosis is excessive loss of bicarbonate ions, so they're not there to buffer the hydrogen. Diarrhea causes loss of bicarbonate from the intestines. Increased use of serum bicarbonate. So the bicarbonate is getting used up because you're losing a lot of it. Renal disease or renal failure can cause decreased excretion of acids and decreased production of bicarbonate ions. So that's going to mess up the whole system. Decompensated metabolic acidosis is when an additional factor interferes with compensation. So something else is going on that's making it worse. So the effects of acidosis, whether it's respiratory or metabolic, are impaired nervous system function, headache, lethargy, weakness, confusion, coma, and death. It's not a good effect. Compensation is rapid deep breathing and secretion of urine with a low pH. So one of the things that they test in the lab is urine pH. And so secretion of urine with a low pH means the kidneys are secreting hydrogen ions because there are too many. We're in acidosis. There are too many hydrogen ions, and so the kidney's trying to secrete them all. Signs and symptoms include compensatory hyperventilation, vomiting, diarrhea, headache, weakness and malaise, hyperkalemia, and cardiac arrhythmias. If untreated, they can lead to continued increase in acid and induce coma and eventual death. So, and then the diagram, you can see lots of different systems are affected by acidosis. So as far as alkalosis goes, metabolic acid alkalosis is an increase in serum bicarbonate ion, so increased pH, increased serum bicarbonate, loss of hydrochloric acid from the stomach from vomiting, hypokalemia, excessive ingestion of antacids. Those can all cause metabolic acidosis. Commonly occurs with conditions such as renal failure, lactic acidosis, starvation, diabetic or alcoholic ketoacidosis, severe diarrhea, or poisoning by certain toxins. So scary. Respiratory alkalosis can be caused by hyperventilation, caused by anxiety, high fever, or an overdose of aspirin. It can be caused by head injuries or a brainstem tumor because the respiratory control centers are in the brainstem. And if they're not being controlled, it messes up your acid-base balance. So a lot of times there's something that's a really serious problem. And the thing that ends up making it worse is that it causes alkalosis or acidosis. So the effects of alkalosis, whether it's respiratory or metabolic, are nausea, diarrhea, prolonged vomiting, confusion, muscle fasciculations, muscle cramping, nervous system irritability, convulsions, paresthesias, and hypoventilation. So lots of things. Increased irritability of the nervous system causes restlessness, muscle twitching, tingling and numbness of the fingers, those paresthesias, tetany, which is cramps, muscle cramps, seizures, and coma. If untreated, the patient can become comatose, experience seizures, and respiratory paralysis. So neither alkalosis or acidosis are situations that you want to get into. So to treat imbalances, the underlying cause usually has to be treated. So immediate corrective measures include fluid and electrolyte replacement or removal, depending on what's going on. Caution is required when adjusting fluid levels to ensure appropriate electrolyte balance. So you can't fix one imbalance and then cause another. So you have to be careful what you're doing. Addition of bicarbonate to the blood to reduce reverse acidosis is a common treatment. Addition of potassium chloride to reduce reverse alkalosis. And after that, modification of the diet to maintain a better electrolyte balance. So that's after you've recovered to get that imbalance treated. The treatment of the underlying cause is the primary focus. So for rehabilitation, higher risk populations for imbalances are patients with renal, cardiovascular, or pulmonary disease. People who have had burns, fever, or sepsis, patients on mechanical ventilation, people that have diabetes mellitus, people that are currently vomiting with diarrhea or enteric drainage, because you're losing ions and fluid from both ends in that case. So the sign, you need to be able to recognize the signs of dehydration in a patient with diabetes, and we will talk about that extensively in the diabetes chapter, which is chapter 16. We won't get there for a while. We need to prevent injury during involuntary muscle contractions that are caused by metabolic alkalosis. So positioning and padding and that sort of thing is important. Patients using diuretic therapy may be at risk for potassium depletion, so that can cause cardiac arrhythmias. Trousseau sign during blood pressure measurements. So when you squeeze their arm with the sphygmomanometer, they indicate a calcium deficiency. So the positive sign, they call it a carpopedal spasm, where your IP joints flex, and the IP joints, wrist, thumb, and MCP joints flex, and hyperextension of the IP joints. So it looks like your hand is a claw, sort of. There's a picture of it in the book. I can't do it that well, but the so that's a sign you're measuring blood pressure and somebody's hand gets weird. It could be a sign of calcium deficiency in early stages of muscle tetany. So here's a case study for acid-base imbalances. So the patient is admitted to the intensive care unit for respiratory distress. There's a clue right there, respiratory. An arterial line is inserted and the arterial blood gas has been sent for analysis. And here's the values that we get back. So pH is 7.2. The CO2 is 56 millimeters of mercury. The bicarbonate ion is 24 milliequivalents per liter. Oxygen is 90 millimeters of mercury, and oxygen saturation is 95%. So the reference ranges, pH should be between 7.35 to 7.45. So when we look at a pH of 7.2, we know that they're in acidosis. The CO2 should be between 35 and 45, and it's 56. So pH is down and CO2 is up. They're opposite, so we know it's respiratory acidosis just from those two values. Their bicarbonate ion is in the normal range, and we would expect that. Their oxygen levels in the normal range, and we would also expect that. And their oxygen saturation is at the low end of the normal range, and we would also expect that. So the two values that are outside the reference range are pH and CO2, and pH is down and CO2 is up. Respiratory acidosis. Okay, so pH and CO2 are the abnormal values. And so this person has respiratory acidosis. And since they were admitted with respiratory distress, are we surprised? No, we are not. So respiratory acidosis. So it's a 6-step process to analyze something like this, if you want to break it down to have a process. So we're going to say, first of all, is the pH normal? And the answer is no. It's acidotic. So it's acidosis. It's either metabolic or respiratory acidosis. Is the CO2 normal? No, it's elevated. So greater than 45 is acidotic. And so respiratory opposite, metabolic equivalent, PO2, pH is low, CO2 is high, they're opposite, so it's respiratory acidosis. They move in opposite directions. Is the bicarbonate normal? It is in this case. So we're going to match the CO2 or the bicarbonate with the pH. Since both the pH and the CO2 are acidotic, we know that the condition is respiratory. So does the CO2 or the bicarbonate go in opposite direction of the pH? Since the CO2 and the pH match, we look at the other system, bicarbonate. Since it's normal and not going in the opposite direction of the pH, this would mean that it's uncompensated respiratory acidosis. You don't need to know this to get the correct answer on this question. It's just supplementary information. And the oxygen level and the oxygen saturation are normal, indicating that the patient doesn't have hypoxia or hypoxemia. You also don't need to know this to get the correct answer. What we need to know is that the pH is low and the CO2 is high. They're opposite, so it's respiratory acidosis, pH low. So that's kind of the analysis on that. And we'll look at a few more of those. So we'll look at some acid-base case studies and some electrolyte case studies and compare the two. So going through that process, we can tell whether it's respiratory or metabolic, acidosis or alkalosis, and whether it's compensated or uncompensated. So pretty cool, huh?